Hello anatomists, let's discuss pulmonary ventilation, or how you breathe. So there's a couple of different terms that we're going to use. Let's make sure that we are up to speed on those. One is atmospheric pressure, and this is just the pressure that's exerted by the air outside the body. So you have no control over this. It's the atmospheric pressure that surrounds your body. Intrapulmonary pressure is also called alveolar pressure, and this is how much pressure is in the alveoli. And this pressure is changing every time you breathe in or breathe out. And it always ultimately will equalize with atmospheric pressure. So that means it will become the same value as atmospheric pressure. Intrapleural pressure is the pressure within the pleural cavity, so between the visceral and parietal pleura, that serous membrane. This also is going to fluctuate with breathing. It is always just a little bit less than the intrapulmonary or alveolar pressure. So as your intrapulmonary or alveolar pressure changes, so does the intrapleural pressure, but it's always a little bit less. So here's a picture of what those pressure relationships look like. Atmospheric pressure, again, is outside your body, and it's normally somewhere around 760 millimeters mercury. Here is your intrapulmonary pressure, right here, and ultimately, although we can change it as we inhale and exhale, it ultimately will always come to the same as atmospheric pressure. So assuming we're at sea level, 760 millimeters mercury. Intrapleural pressure is always going to be just a little bit less, about 4 millimeters mercury less than intrapulmonary pressure. And so you can see it's 756. And sometimes we just refer to it as -4 because it's usually about 4 millimeters mercury less than intrapulmonary pressure. So here's the space in between those membranes, the visceral and parietal membranes. This is the pressure inside your alveoli, which is your intrapulmonary pressure. And finally, atmospheric pressure is outside your body. When you have a lung collapse, this might be due to a plugged bronchiole, or you might have air that enters the pleural cavity if you get a wound in your lungs or in your thoracic cavity. This causes the alveoli to collapse. The reason that your lungs stay inflated is because of that slightly negative pressure that acts like a plunger on your lungs. I'm going to move back for a second. When I look at this intrapleural pressure value, I think of intrapleural pressure like a plunger. It's constantly sucking your lungs outward, that visceral pleural layer. So it's constantly sucking your lungs outward. If you have damage to this layer right here, if you have some kind of trauma, for example, and now this pressure can equalize with atmospheric pressure on the outside. So now this is no longer -4. You no longer have that suctioning that's happening, keeping your lungs inflated and open, and because it has now equalized with atmospheric pressure. And so when you have a lung collapse, it's because this pressure has equalized. So the intrapleural pressure is really important for, I think of it like a plunger, sucking your lungs outward, keeping them inflated. So you have your alveoli collapse during atelectasis, which is a lung collapse. If you get air in the pleural cavity that gets stuck in there, that's called a pneumothorax. You can also get other things that get stuck in there, debris. You can get blood that fills the pleural cavity, and you need to suction out whatever happens to be it, whether it's air or blood. There'd be a hemothorax. You'll need to suction it out with chest tubes. So, lung inflation. Your thoracic cavity is configured to expand outwardly, and you have lots of elastic tissue to help it recoil back to its original shape after expansion. And that, again, that intrapleural pressure, that -4, is going to help cause the inflation of the lung. So let's look at what it takes to inhale, to bring air into your lungs. What you need to do is establish a pressure gradient. You need to make the pressure inside the alveoli less than the atmospheric pressure that's outside your lungs. And the way that you achieve this is by increasing the size of your lungs. Boyles Law states that the pressure of a gas in a closed container, like your lungs, is inversely proportional to the volume of the container, which basically means volume goes up, pressure goes down, and vice versa. If pressure goes down, volume goes up. So if you can increase the volume of your lungs, increase the size of your lungs, if you expand your lungs, then this will bring pressure down in your alveoli. Then air can move from an area of higher pressure in the atmosphere to an area of lower pressure inside your lungs. And it's just a passive movement. So here is an illustration of Boyles Law. You can see that we have some molecules in here. These are oxygen molecules. And in this space, they don't really have much movement area. There's not very many places they can go. And so this piston is pushing down, showing that this pressure is increased. Volume is 1/2 liter, pressure is 2 atmospheres. But if we bring this piston up, we're increasing the volume of our container. So now it's at 1 liter, used to be 1/2 liter. And as we increase the volume, we've decreased how much pressure is on it. So we've moved from 2 atmospheres to 1 atmosphere. So as we increase the volume, we decrease the pressure. That's what Boyles Law states. How are we going to increase the size of our lungs? We do need to contract some muscles for this to happen. There are 2 main muscles that you're going to use. The most important one is the diaphragm. Normally the diaphragm is kind of dome-shaped and it pushes up into your thoracic cavity, but when you contract it, you flatten it out and lower it down. And this muscle alone is responsible for about 75% of the air that enters your lungs during regular, quiet breathing. Your external intercostals are also important, and they're responsible for the rest of the air entering your lungs. As you contract your external intercostals, which are located along your ribs, their contraction elevates the ribs, bringing your rib cage outward. And so you have your diaphragm that kind of flattens out and pushes down, your external intercostals that brings your rib cage out. And so this is how you increase the volume inside your lungs. Now these are the only 2 muscles that you're going to use when you're just breathing quietly at rest. If you are performing very deep, forceful inhalations, there are additional accessory muscles that you can use. So for example, you have your sternocleidomastoid muscles, you have scalene's muscles right here that can help to elevate some of these upper ribs. And if you are forcefully expiring, you also have additional muscles to use. So when you exhale, it's just a passive process. You relax your diaphragm and external intercostals. But again, if you are using forced expirations, if you're playing a musical instrument, for example, or blowing bubbles underwater, you can use additional muscles. Internal intercostals, diaphragm, abdominal muscles such as the rectus abdominis. This helps to push the air outward a little bit more forcefully. So this is just an illustration of some accessory respiratory muscles. The primary ones that you use, especially during quiet respirations, will be the diaphragm right here, and then your external intercostals located between your ribs right here. So we have muscles that can increase the volume of our thoracic cavity, increase the volume of our lungs. And so as the volume increases, alveolar pressure inside of our lungs drops. And so air can move passively from an area of higher pressure, the atmosphere, to lower pressure into our alveoli. When you exhale, everything goes backwards. You have your diaphragm that will relax, and so it moves back up into its dome shape, pushing up into your thoracic cavity. You have external intercostals that relax, bringing your rib cage back down toward the rest of your body. And this, just in normal quiet exhalations, this is an entirely passive process. So you're not contracting any muscles, you're just relaxing them. But again, if you're using forceful breathing, you can use additional muscles. And as that volume goes down, as these muscles relax, the pressure increases. So pressure and volume are inversely related. Volume goes down, pressure goes up. Now you have a higher pressure inside your lungs than you do on the outside in atmospheric pressure. Again, air will move passively from inside your lungs to outside your lungs. So let's look at a picture that helps illustrate this. So here you are at rest. Here's your diaphragm that's kind of dome-shaped. You're relaxed right here. You'll notice that your alveolar pressure on the inside of your lungs is the same as atmospheric pressure. So both are at 760 millimeters mercury. Intrapleural pressure, so our suction, our plunger on our lungs, is about 4 less. During inhalation, your diaphragm flattens out, makes more space in your thoracic cavity. As volume increases, pressure goes down. So now let's look at our alveolar pressure. You'll notice these numbers are pretty similar, but they've changed enough. Alveolar pressure has gone down, and it's less than atmospheric pressure. Air moves passively from an area of higher pressure to an area of lower pressure inside your alveoli. Notice our intrapleural pressure also changed. It remains about 4 less than our alveolar pressure. When you relax, when you exhale, so your diaphragm relaxes and moves back up into its dome shape. Your external intercostals aren't pictured, but they'll relax as well. These cause the volume of your lungs to decrease. And so as the volume of your lungs goes down, pressure increases. Let's look at our alveolar pressure. It's up to 762. That pressure is more than our atmospheric pressure, which is 760. And so again, it's not a huge difference, but it is enough. We have higher pressure in alveoli. Air moves from that higher pressure to an area of lower pressure outside of our body. And then again, our intrapleural pressure just keeps tagging along with our alveolar pressure, always staying around 4 less than alveolar pressure, approximately. Notice during this whole process, atmospheric pressure never changed. It stayed the exact same value. What we manipulated was lung volume and alveolar pressure. And so by increasing the volume, we decrease alveolar pressure, air moves into our lungs. And by decreasing the volume of our lungs, we increase the alveolar pressure, and then air will move out of our lungs. Airflow is how much air moves into and out of the lungs with each breath. And this is determined by a couple of things. One is the pressure gradients, which is exactly what we were just talking about. What is the difference between atmospheric pressure and intrapulmonary pressure? In the numbers that we used in the previous picture, there were not really big changes between the numbers, 2 to 3 millimeters mercury. You can imagine if you were to change that and make the numbers more different, for example, if you had a larger gradient, a more steep gradient, then flow would be increased. If you have less of a gradient, so if atmospheric pressure is closer to your alveolar pressure, then you will not move air as quickly. So the pressure gradients will play a role in determining airflow. Also, resistance will help determine airflow. And if you have studied blood vessels and blood flow, then some of these things should sound very familiar. Flow is directly proportional to the change in pressure, which is what we just talked about, pressure gradients. Flow is inversely proportional to resistance. And you have resistance that's possible in your air carrying vessels, just like in your blood carrying vessels. So things that can adjust resistance. You can have a decrease in the elasticity of your chest wall or lungs. You have lots of elastic tissue in your lungs, but over time that elasticity can decrease. You can also change your bronchial diameter. You have bronchoconstriction and bronchodilation. If you have bronchoconstriction, that air meets with more friction because it comes in contact with the walls of your bronchioles more often. And so that will increase resistance if you have bronchoconstriction. If you have collapse of alveoli, you are decreasing how much surface area is available in the respiratory membrane, and that increases resistance. And you can have the same kind of thing happen if you have damage to your alveoli. That can affect resistance as well. So just like with the blood vessels, flow is determined by changes in pressure and resistance. If you increase the pressure gradient, the steepness of the pressure gradient, that increases flow. If you increase resistance, that decreases flow. So here's that equation that hopefully looks familiar. Flow is equal to the change in pressure, or your pressure gradient, over resistance. And you also have alveolar surface tension. This draws your liquid molecules, such as water, blood, closer together. Water has a really high surface tension, and it always acts to reduce alveoli to as small as possible, which is why surfactant is important. The way that surfactant works is it decreases the cohesiveness of water. So you may remember, due to the hydrogen bonding properties of water, that water tends to stick to itself. Water molecules stick together. Surfactant decreases this property. It decreases cohesiveness. So water doesn't want to stick to itself quite as much, and that decreases the surface tension. And so that helps to reduce resistance.